Right now, we will welcome Professor Dai嘉言, Vice Superintendent of Kaohsiung Medical University Hospital, KMUH, Taiwan, and he will present hepatocellular carcinoma treatment in Taiwan, sharing national strategies and institutional expertise in managing liver cancer, one of the most prevalent malignancies in Asia. Let us welcome Professor Dai.
Thank you, dear colleagues, ladies and gentlemen. It's really my great pleasure, and I'm so glad to participate in this forum and now have this opportunity to discuss with you this topic. Please, my slide. I'm Dr. Dai, comes from Kaohsiung, so welcome to Kaohsiung, Taiwan. Okay, let's look at the standardized incidence of cancer. You can see the liver cancer is on the downward trend. And how about the mortality? Also, you can see the liver cancer is also a downward trend. So we will look at the HCV causes. You can see so many patients may cause from HPV infection. Of course, if a country, for example, Japan, you can see maybe higher HCV prevalence. So the HCC will cause gradually from the HCV in that country. So let's look at the HCC condition in Taiwan. You can see HBV 42% and the HCV 28%. And also you can see the female will cause more by the HCV infection. You can see here. And also in southern part of Taiwan or middle part of Taiwan, the HCV is higher than the HBV. So this is the major causes change or the distribution difference between all the areas and the gender. Let's look at the HCC risk factor. You can see for the male, indeed, HBV is very important here. And for the female, HCV is more important. However, I want to draw your attention. You can see the non-B, non-C, the blue part is increasing. Okay, let's look at the cascade about the HCC. Of course, the patient with HCC or decompensation with major outcomes. When we take the example of HCV, for example, we can see patient with acute infection, then get chronic infection, then get cirrhosis, and also maybe have HCC. So we have to make a prevention. The first one, maybe we have to do the prevention by vaccine. However, no HCV vaccine now. So we have to treat the patient as a prevention. Then the second antiviral treatment, we can get the prevention for the cirrhosis and HCC. And also we have the tertiary prevention. Even patients have HCC, we may treat them. Okay, this is a very important slide. The Taiwan National Health Insurance has reimbursed the treatment since 2017. You can see we have very good drug here now. And currently, we can treat the patient treated by the DAA is free, all free. So how about the condition of the results? You can see here, the first one is the SVR by the National Health Insurance. You can see 98%, and the SVR rate is very high. You can see here, by the real world data, we have shown more, maybe 99 to 100% of patients can get cured. So now the major problem is the screening for the patients. How about hepatitis B? You can see Taiwan is the first country to initiate the mass vaccination program for the newborn. So you can see since 1984, the HBsAg prevalence decreased from 10 to 0.9 or even 0.5% in the newborn. And you can see also for the students in the university, born after 2000, you can see almost no patient get HBV. So I think I will lose my job soon. Now we don't have B or C patients, maybe. Okay, let's look at the treatment. Also, antiviral treatment is reimbursed by the National Health Insurance. Patient is free for the treatment. Also, we have applied the nucleoside analogs, to treat the patient for HCC patient. So this is very important to prepare. I think the KLCA said for the HCC, the prediction is very important. This is, I think, one of the most famous study published, you can see from Taiwan. The HBV DNA viral load is very important to predict HCC. And you can see, if you combine with the sex age or other clinical parameters, you can also develop, for example, the RICH-B score. And the RICH score can also predict the HCC very well. So we have to try to find the high-risk patients by this score. How about HCV? Okay, you can see after SVR is important. So FIFO nowadays is to evaluate the fibrosis of patient. And then you can see we can use the elastography, that is also FibroScan. You can also to try to measure the liver stiffness and then just guess the fibrosis of the patient. And also we may have some models. For example, US models, or this is AMAP. So AMAP, you just do so many clinical factors together by this formula. Of course, this is a very complicated formula. Then you get a score here. You can identify about 18 to 20% of patients with very, very high risk. So we have to develop the screening strategy for these kinds of patients. So prediction is very important by this score. Also, we want to improve that. So you can see we published this paper with the baseline and at the end of treatment, FIFO score. And how about the change? If the patient change less, not change much, not improve much, okay, you can see the HCC incidence is higher. So that is also very important if you try to monitor the patient before and after treatment by this way. And also we try to publish paper to try to improve. You see the GALAD. The GALAD score use 5, and in Japan use the ALP-L3. So the ALP-L3, we just skip that. We have seen that this GALAD score is also very good for the GALAD score. So in Taiwan, we don't use the ALP-L3. We just with all the others try to make a good prediction for the HCC. Okay, so we need in the future, the unmet need may be a more better risk prediction models for the HCC patient. So for the treatment, you can see the HCC patients, if very early stage, we want to cure. However, if a patient with advanced HCC, we have to try to maybe just prolong the overall survival and try the best to get cured. The BCLC staging is very important nowadays in evaluation of patient with HCC for treatment. You can see very early stage, or early stage we can get ablation, resection, or transplantation, surgery, etc. And if the later stage, now systemic treatment is very, very important for the patient. For the intermediate stage, currently we use TLCA. Also, we may combine other modality, and also we may try to let this paradigm shift to left. We use systemic therapy. Earlier, it may be in the intermediate stage of the HCC. So this is the Taiwan Liver Cancer Association have done this treatment guideline. You can see here. So I want to show you just by the HbA spread, the child score, that is liver reserve function or the vascular invasion, etc. We may try to group the patients, give the indication for the patients with HCC. So this is Taiwan's guideline. And how about the surgical and the radio frequency ablation? Now, just very easy. Previous resection is always superior to the RFA. You can see the overall survival or disease-free survival. However, recently you can see if you look at the propensity score matching, after that you can see the overall survival rate is similar between surgical resection and the RFA. Okay, similar. However, you can see now also here the recurrence rate is higher for the radio frequency. Of course, we need to improve. I think we have improved the radio frequency, maybe the technique or something like that, so we can get a better overall survival. And also you can see now microwave ablation from the initial now make an improvement. Now we also have cryoablation here or other modality for the radio frequency ablation. That is the job for the medical doctor like us. So we do the best, and you can see here the new generation microwave can improve and or even do better than the RFA. So I think the technique is get improved, and I think the outcome will become better. How about the treatment or the final the guideline? So you can see for the advanced patients, you can see initial with the target therapy here, and then we have the ICI-based therapy, maybe immune plus target therapy or immunotherapy, ICI plus ICI double immunotherapy. And also the NCCN also have guidelines to make some recommendation for the first-line therapy. Indeed, the systemic therapy for advanced the patient is quite good. However, you can see here, if we combine local regional therapy, we can see by the local regional therapy, we can enhance the immune reaction, maybe by the antigen release, improve all the anti-inflammation, etc. Under this condition, the ICI will work better. So I think combination is very important. And currently, we use that. For example, some suggestions just that for the TLCA patients, you may add, for example, the ICI, double ICI or ICI with the tachytherapy, etc., to improve that. Maybe we can get a better response for them. Okay, a case maybe by multi-modality treatment, so maybe initially by sorafenib and then maybe do that with the radiotherapy for portal thrombosis, then with the yttrium, that is TRE, etc., to try to get better, and then finally can get the very good result and get a resection here. So I think we may do the best to let the advanced patient try to get the surgery or something like that to get a cure. So that is the patient. So then I want to make an emphasis that the TLCA, Taiwan Liver Cancer Association, also have published the intermediate stage consensus. So you can see here, TLC may be not suitable for some patients. Many lesions or unsuitable. You can see here, unsuitable. Oh, I'm sorry. Unsuitable here. Or sometimes TAC refractory use the immunotherapy or the E390 radio ablation, or sometimes we can use the drug-eluting bead, the TAC, or try to cure conversion. After that, we get operation or liver transplantation for them. So now we have three kinds of major treatment. These two has been reimbursed in Taiwan. So patient did not pay any dollars to receive the atezolizumab or the tremelimumab. However, not yet for the Nivo EP. So you can see the ORR is about 20 to 33%, and also the stability is maybe achieved 30 to 40%. So I think that is quite good, but however, we have to make efforts to improve that. So this is national health insurance reimbursement in Taiwan. We can use atezolizumab for the patient. And I want to show you this data comes from Taiwan. The median overall survival is 2 years. Okay, that's quite good. I think it's quite good. I think we have to do more and do better for these patients. And you can see the Himalaya, that is also the tremelimumab. We can now use it just 4 months ago. The National Health Insurance reimbursement, okay, for this drug. Okay, let's look at for the HCV patient. Because most of the Taiwan patients, we want to eliminate the HCV this year, 2025, not 2030 by the WHO. So most of the patients are cured. So you can see after cure, some patient will become loss of immune surveillance. You can see some, for example, you can see here, the TNF-alpha or T-weak, etc. So this change and combined with other parameter, we can get a score then to predict the patient about the HCC. So this is a major work we have to do after the HCC cured. So you can see here, the ESO, European, and the ASLD, that is USA, have published this one, and the APASO is for ASEAN Pacific area. We have tried, in Taiwan, we try to screen all the patients, but you can see here, there is some factor that means the patient is high risk. So for these high risk patients, we have to do more or frequently screen these patients for HCC. Another interest is we published a paper, and you can see here the epigenetic dysregulation. For the patients get these kinds of epigenetic dysregulation, we can check that. For example, this is one. Now you can predict the HCC occurrence very well. However, if you combine several together, you can have this map. You can try to do this. For example, patient treated with HCC or cure, you can see the epigenetic dysregulation seems not changed. However, if you add some medication, for example, here, you can add the histone acetyltransferase inhibitor or just do the erlotinib. You can see all the dysregulation seems changed, or we can say that improved. So under this condition, I think we may use this kind of strategy to treat the patient. If the patient get cured, then we may try to add some medication to change the epigenetic dysregulation. Maybe we can try to stop or try to decrease the occurrence of HCC. This is quite important. Another paper we published in Journal Hepatology, you can see DM patients treated with metformin. Okay, that seems may decrease or reduce the risk of HCC in DM patient. So we may have, for example, recently starting also may be. So we may have some other strategy to decrease or reduce the risk of HCC for patient. Lastly, I want to show the AI. The AI is important in the care of liver diseases, for example, hepatitis or HCC. You can see we have routine data. We have also radiology. We have also pathology data. And then we can do the multi-omics. And then nowadays we can real-time monitoring. And then at last, we may add the natural language processing to help us. For example, we have do this study. We try to elucidate the patients with these kinds of genetic data. And now go to the machine learning with the random forest, try to find some predictors. So you can see here, after this work, you can see some predictive model just regenerated. And generated this to try to make a prediction. You can see downregulation of the phosphorylated 3 markers significantly increase the risk of HCC after HCC clearance. So I think the AI develop is also very important for us in this era of the patient most cured by the patient. And the others, we have to find some non-hypervascular hypotensive nodule or this display nodule, etc. This is a high risk for HCC. So we have to watch for these things. And I think learning or the machine learning is quite important for patient. Currently, to get the patient treated by surgeon, for example, operation, or indeed by this way, by liver transplantation, this is our hope to get patient cured even they have the advanced HCC. Now you can see here, maybe combined with LPL3 or DCP, we can predict early HCC. You can see here, you get a cutoff, you can clearly identify some patient with high risk. With different together, okay, that's better. And if you change the cutoff, of course, that's better to differentiate the patient or identify patients with higher risk of HCC. So we may try to improve these kinds of prediction, just like I have said. And then finally, I want to emphasize that patients without liver cirrhosis, we published a paper, you can see so many patients without cirrhosis also get HCC. So we should pay attention to these kinds of patients. So I think that to predict or to identify patients with high risk is very, very important for them. Okay, so nowadays we want to emphasize all the screening modality or screening method. The last 2 slides, I want to show that if you see nowadays the muscle, that is metabolic associated or metabolic dysfunction associated steatotal liver disease, now increase the HCC risk in Taiwan. We published this paper. You can see clearly the muscled patient will have high risk of HCC. So this may be after we treat B and C and the cure B and C, we have to make some attention to that. However, the last slide I want to show you, our published paper show that hepatitis is more important. Hepatitis B, hepatitis C is more important. We have to try our best to do that, to cure them, and then watch for the effect or impact of muscles for the HCC occurrence. That's my last slide. I want to thank you very much and welcome to Kaohsiung, Taiwan. Thank you.